Very good morning. I'm Dr. Santhosh. Last class we had discussed regarding the topic on thyroid goiter. Today we shall discuss regarding toxic goiter. Okay. Let us know what is the difference between hyperthyroidism and thyrotoxicosis. Okay. And the term thyrotoxic is retained. It is because the hyperthyroidism, that is symptoms due to raised levels of circulating thyroid hormones. Okay. Thyrotoxin is nothing but the state of increased circulating thyroid hormones, irrespective of the source. And hyperthyroidism is one in which the origin of surplus hormones from increased production of thyroid gland. Okay, and in this, the hyperthyroidism is which states that okay, it is because of the increased production of thyroid hormone, thyroid gland. Okay, and the manifestation is the thyrotoxicosis. It is a state of increased circulating thyroid hormones, thyrotoxicosis. So hyperthyroidism will lead to thyrotoxicosis. Okay, so coming to what are the causes of hyperthyroidism, the most common cause being Graves disease. Okay, followed by toxic multinodular goiter. You would have known, we have already discussed regarding thyroid adenoma, solitary thyroid adenoma, which is the hyperactive thing which secretes these thyroid hormones, followed by thyroiditis, subacute lymphocytic or drug induced thyroiditis, or iodine induced, that is amide iron induced, or thyrotoxicosis factitia. This thyrotoxicosis factitia is nothing but when you consume excess of the exogenous thyroxine, that is T3 T4, that is when you that is T4 when you consume X in excess, that is exogenous thyroid hormones. Okay, so broadly it is divided. This toxic goiter is broadly the causes being diffused toxic goiter, that is Graves disease, as we already discussed, and followed by toxic multinodular goiter and toxic nodule and thyroiditis. These are the main classifications that comes under toxic goiter. Okay, so let us discuss in detail regarding what is Graves disease. See, Graves disease, it is nothing but it is a diffuse vascular goiter appearing at the same time as a hyperthyroidism, usually occurs in a younger woman and infrequently associated with eye signs, that is ophthalmopathy. Okay, syndrome. This syndrome is that of a primary thyrotoxicosis. 50% of the patients have a family history of autoimmune endocrine diseases. Okay, and the specialty is that TSH receptor activating antibody will be produced in this Graves disease. Okay, more common in females. The ratios between being 7 to 10 is to 1 in F1 for every one male person. Okay, thyroid receptor antibodies are produced here in this Graves disease, which acts on this TSH receptor, which is there on the thyroid gland. Okay, this leads to the activation of adenyl cyclase, which in turn increases thyroid hormone production from the thyroid gland. Okay, what are the manifestations which can lead to this because of this Graves disease? The main things are the thyroid gland findings, that is the goiter and bruit can be heard. So because of this manifestation of thyrotoxicosis, patient will have ophthalmic findings, proptosis, ophthalmoplegia, conjunctival irritations, and you can see the dermatological findings as well, the dermal myxedema, that is soft tissue, the swelling and hair loss. Okay, so infiltrative ophthalmopathy, what are the things? This is because of the thyroid receptor antibodies, that is the TSH receptor antibodies binds to the TSH receptor antigen, that is the which lead to T cell response leading to cytokines, followed by fibroblast proliferation and glycosaminoglycans deposition in the retrobulbar region in the eye, behind the eyeball, which leads to this proptosis. Okay, so this is called the infiltrative ophthalmopathy, seen in 20 to 40% of patients with Graves disease. Only severe cases needs treatment. That is only about 3 to 5% will go to lead into severe thyrotoxicosis, which will lead to this ophthalmopathy. Treatment is the glucocorticoids. Okay, orbital rate therapy and orbital decompressive surgery can be done. Up to 10% are usually euthyroid state. Okay, dermatological findings. usually when you hear what is called the myxedema is usually seen in the is usually seen in the severe hypothyroidism. But in case of Graves disease, you can also see localized dermal myxedema in seen in about 0.5 to 4% of patients, always with a pre-existing ophthalmopathy. Okay, with this presentation, all obviously with this thyrotoxicosis patient will have a ophthalmopathy. 13% of the patients will develop myxedema, usually pre-tibial, in areas that undergo trauma, depending areas. That is the diffuse non-pithing edema is the most common presentation in about 43%, followed by plaque formation. Okay, and least common are the nodular myxedema and elephantiasis. Okay, and in about 5%. Okay, what is the treatment? Topical glucocorticoids for severe palms, followed by compressive bandaging. Okay, what is this thyroid acropathy? Thyroid acropathy is nothing but, as we already discussed, this is related to the soft tissue swelling followed associated with clubbing. Okay, seen in about 1% of patients. It consists of digital clubbing, soft tissue swelling of the hands and feet, periosteal bone formation. Okay, almost always occurs in patients with myxedema and ophthalmopathy. Okay, this was regarding the Graves disease. Okay, this was the only manifestations. Treatment we'll discuss in the subsequent slides. The second most common cause for this thyrotoxicosis is the toxic nodular goiter. Okay, toxic nodular goiter, this is a simple nodular goiter is present for a long time before the hyperthyroidism. Okay, usually in the middle age or in the elderly. It is the second most common cause, and it is usually from the long standing multinodular goiter. Prevalence increased with iodine deficiency. Okay, when there is iodine deficiency, obviously the prevalence is there. Presents in older than 50 years and in case of multinodular goiters, usually in the middle age and elderly, and is very infrequently is associated with eye signs. Okay, you unlike in the Graves disease, usually there is no eye signs in this. Okay, in most cases of the toxic nodular goiter, the nodules are inactive, and it is the internodular thyroid tissue that is overactive. Okay, and usually that we already discussed, third to fourth decade, in 60% of the patients, that is TSH receptor gene, that is somatic mutation, leads to activation and upregulation of cyclic AMP. Okay, and this is regarding the pathology. However, in some toxic nodular goiters, one or more nodules are overactive, and here the hyperthyroidism is due to autonomous thyroid tissue, as in the toxic adenoma. Okay, this can also present as represent something like a toxic adenoma. Okay, clinical presentation, usually thyrotoxicosis is mild, often presents with serious manifestations. Okay, and what are the other features? Okay, what are the lab findings? Usually the T3 T4 will be elevated with decreased TSH values. Radioactive iodine uptake in case of this toxic goiter is the heterogeneous pattern with focal areas of increased uptake. Okay, and what is the pathology? Okay, see, in these genetic factors and environmental factors will act on the antigen presenting cells, which leads to activation of either interleukin 12 and 14 and 4, which in turn activates the CD4 T cells. Okay, so Th1 cells and Th2 cells, which activates, this leads to cellular immunity. Okay, FAS expression of thyroid cells, thyroid cell apoptosis, which in lead to Hashimoto's thyroiditis. So in this Hashimoto's thyroiditis, it is not the TSH receptors, which the TSH binding receptor antibodies which is there. It is in this the Hashimoto's thyroiditis. You can treat TPO antibodies, thyroid peroxidase antibodies. You can find in the Hashimoto's thyroiditis. Okay, Th2 cells, when it get activated, it leads to humoral immunity, anti-TSH receptor antibodies, just like we saw in the Graves. It causes stimulating, it causes the Graves disease. When it leads to blocking, when it lead to blockage of this antibodies. Okay, by these antibodies, it can lead to atrophic thyroiditis. Okay, this is regarding the pathology. What are the lab findings? TSH values will be elevated, T3 will be diminished, T3, T4 will be elevated. And what about thyroid receptor antibodies? In case of Graves' disease, 70 to 100% you can find this thyroid receptor antibodies. In case of Hashimoto's, as we already discussed, thyroid peroxidase antibodies will be there, and antithyroglobulin. Okay, in 70% of Hashimoto's and 30% of Graves' disease. Okay, what about this T3 T4 ratios? T3 toxicosis. Okay, in case of Graves and toxic multinodular goiter, T3 bar T4 will be more than 20. Okay, and in case of thyroiditis and exogenous intake of T4, the T3 T4 ratio will be less than 20. Okay, what are the other investigations which help in diagnosis of this grave this thyrotoxicosis? Okay, in case of Graves, there is a homogeneous uptake in case of Graves disease. This is the first diagram. Okay, in case of toxic multinodular goiter, there is a heterogeneous pattern with hyper functioning nodules and suppressed background. Okay, this is about the toxic multinodular goiter. Okay, okay, thyroid ultrasound, what and in what way does it help? It helps to identify the toxic nodules and the goiter. Okay, Doppler flow assessment of that ultrasound helps to differentiate between the hypermetabolic and destructive glands. Okay, coming to, okay, we shall discuss regarding what is the how do you manage this hyperthyroidism in toxic goiters. Okay, mainly it is by the antithyroid drugs mainly. Okay, we shall I shall discuss, I shall tell in this the mainly there are these three treatments. Okay, one is the antithyroid drugs or radioactive iodine. Okay, or if there is a surgery, obviously the toxic goiters, when there is no means subsiding of the symptoms with the antithyroid drugs or by the radioactive iodine, obviously the patient will be subjected to surgery. Okay, and initial management is by the antithyroid drugs. Okay, antithyroid drugs, what does it this are by the thionamides. Okay, thionamides, these are nothing but imidazoles, methimazole and carbimazole and thiouracil, that is propyl thiouracil. These are the drugs. How do this act? It acts by the inhibition of organification of thyroid hormone. Okay, this inhibitory effect on immune system, that is it reduces ICAM1 and IL2 and HLA class 2 expression. This induces apoptosis in the intrathyroidal lymphocytes. Okay, use of this high dose thionamides with thyroid replacement is recommended currently. Okay, okay, this the common drugs are these are the carbimazole and propylthiouracil. These antithyroid drugs are used to restore the patient to a euthyroid state and to maintain this for a and this is maintained for a prolonged period in a hope that the permanent remission will occur. Okay, the production of antithyroid antibodies will diminish or it will decrease over a period of time with these antithyroid drugs. So, these antithyroid drugs cannot cure a toxic nodule. Okay, the overactive thyroid tissue is autonomous and recurrence of the hyperthyroidism is certain when the drug is discontinued. So, these are the side effects of this drug. So, you can't stop in between in case of toxic nodule. Okay, this won't be of any help. Okay, means when obviously when you stop, this will recur. Okay, propyl thiouracil has shorter half-life, that is 1 to 2 hours compared to other drugs, that is carbimazole. Methimazole once daily dose is the preferred drug, is the preferred. Okay, dosage of methimazole is 15 to 30 milligram per day. Propyl thiouracil 300 milligram per day in 3 divided doses. Okay, what are these adverse effects of thionamides? Abnormal taste, pruritus, arthralgia and urticaria. These are the common manifestations. Okay, by taking of this drug, cutaneous symptoms managed with antibiotics along with this therapy. Other complications like egg granulocytosis can be seen. Usually occurs in the first 3 months. Okay, seen in about 0.2 to 0.5%, especially with more than 30 milligram of methimazole. So monitoring counts are not recommended. So other complications like hepatotoxicity will be there. Okay, in pregnancy it causes placenta. So propylthyrox is safer than methimazole. Okay. So what is this? What are the advantages of this antithyroid drugs? So if I have to tell this there is no surgery and no use of radioactive material in case of antithyroid drugs. Okay, what are the disadvantages? Treatment is prolonged and the failure rate is about 50% in case of this antithyroid drugs. The duration of treatment may be tailored to a severity of its toxicity. In milder cases, being treated for only 6 months, and in severe cases, 2 years before stopping this therapy. Okay, these are the advantages. Okay, coming to what is this beta blockers. Okay, so beta blockers, they are used for cardiovascular and hyperadrenergic manifestations. First used in 1966. Propranolol most commonly used. Okay, so these are the beta adrenergic blocking drugs. Okay, and more cardiac beta adrenergic receptors and high metabolism in thyrotoxicosis. Larger doses of more than 160 milligram per day reduce the T4 levels by 30%. So these are the actions of these beta blockers. Other options other than propranolol, atenolol, metoprolol, and nadolol. Okay, so how do this act? They act by using the beta adrenergic blocking drugs. They act on the target organs and not on the gland itself. Propranolol also inhibits the peripheral conversion of T4 to T3. Okay, the action of this propranolol is by inhibits the peripheral conversion of T4 to T3, and that's how this inhibits. Okay, and the dosage, as we know, like atenolol 5 to 100 milligram per day. Okay, coming to what is this inorganic iodine. Okay, this iodine it can may be given with carbimazole or beta adrenergic blocking drugs for 10 days before operation. Iodine alone produces a transient remission and may reduce vascularity and produces, okay, reduce the vascularity and thereby marginally improving the safety. Okay, and in cases of severe thyrotoxicosis, it acts by Wool-Chekhov effect, that is it blocks the release of hormone, it decreases iodine transport, it prevents oxidation. Okay, thionamides administered along with iodine 1 hour prior. Okay, excuse. So what is this? Supersaturated potassium iodide or Lugols. It's a 5 drops of Lugols per day. Okay, it is given. So it is to decrease the vascularity as we already discussed. Okay, it is used to decrease the vascularity. Iodine along produces transient remission and may reduce the vascularity, thereby marginally improving the safety. Okay, before surgery it is given. So what is this? Potassium perchlorate is a second line treatment. Rare risk of aplastic anemia. Best used as a bridge to definitive ablative therapy with radioactive iodine. Okay, or thyroidectomy. Okay, what is this? Lithium and cholestyramine. Lithium, it is used in combination with methimazole or propylthiouracil. It reduces hormone secretion. It inhibits the coupling of iodothyroxine residues. Okay, and the serum lithium is maintained by less than 1 milliequivalent per liter. What is this cholestyramine? It is an anion exchange resin. It reduces absorption from enterohepatic circulation. Cholestyramine, okay, can be used along with thionamides. So all these are the drugs which are used for the treatment. Okay, and the first is the antithyroid drugs, and second what we are discussing is the radioactive iodine, where and all we use. Okay, followed by the surgery. Okay, now the second is the radioactive iodine. Okay, where and all it is used. Okay, how do this act? Radioactive iodine, it is an effective agent for delivering high radiation doses to thyroid tissue. Okay, it emits mainly beta radiation. 90% it is the beta radiation. Okay, it emits beta radiation, that is beta particles, and gamma rays as well. Okay, beta rays are utilized for their destructive effects on thyroid cells. Okay, so the side effects of are the permanent hypothyroidism, radiation thyroiditis, gastritis, sialadenitis. These are the side effects of this radioactive iodine. May increase the risk of secondary malignancies. Okay, so this will increase the secondary malignancies. Okay, So goal is to render the patient hypothyroid. Okay. And about this radioactive iodine, it, so how does this act? This is the radioactive destroys the thyroid cells as in the thyroidectomy reduces the mass of functioning thyroid tissue to below a critical level. Is just like the thyroidectomy, it reduces the mass of the functioning thyroid tissue to below a critical level. Okay. It dose depends on the gland size and radioactive uptake. Minor risks of exacerbation of thyrotoxicosis, that is the role of pre-treatment with methimazole reduces the risk but discontinued in 3 to 5 days priorly. Okay. Hypothyroidism takes about 2 to 3 months. Okay. So continue thianamides. Retreatment is required if not hypothyroid in 6 months. Okay. So in case of Graves disease, how what is the treatment? So initially you give antithyroid drugs, and for or beta blockers. Okay, this will lead to euthyroid state. So even after like giving drugs, it is not subsiding. Then the following, then you will subject the patient to radioactive iodine or surgery. For remission, you can use methimazole 5 to 10 milligram per day. Okay, for 12 to 8 months of treatment. Okay, then you can taper and stop with a close follow up. Okay, in 50 to 60%, as we already discussed, it can recur. Failure of this treatment, antiviral drugs, you can subject the patient to radioactive iodine or surgery. And for ophthalmopathy, so you the treatment is IV or oral glucocorticoids. So post radioactive iodine therapy, prednisolone for ophthalmopathy. If there is ophthalmopathy persisting, then you can give prednisolone. And smokers usually have poor outcomes in case of Graves disease. Okay, what is the treatment of toxic nodular goiter or adenoma? Okay, in case of antithyroid drugs. Okay, so antithyroid in case of, okay, in case of toxic nodular goiter, okay, you will give antithyroid drugs for euthyroid for to get into the euthyroid state. Okay, almost certain to recur after cessation of antithyroid drugs. It is already known. Okay, definitive option is the radioactive iodine or surgery. Okay, and the role of radioactive iodine, larger doses may be needed, about 15 to 30 millicurie. Okay, recurrence rate of radioactive iodine therapy is 20%. Okay, so you will subject the patient to surgery. Okay, or you can repeat the radioactive iodine, or you can subject the patient to surgery. Okay, coming to what are the final thing, what is the important, that is the general indications for surgery in preference to radioactive iodine for the treatment of hyperthyroidism. Okay, what are the general indications for surgery in preference to radioactive iodine? So where and all you indicate the patient for surgery? Okay, absolute indications, these are like being suspicious or biopsy proven malignant nodules, so you should subject the patient to surgery. You can't go in for radioactive iodine. Comorbidity also requiring surgery, that is the in association with hyperparathyroidism, in that case also as well. Inability to use the radioactive iodine ablation, that is the pregnancy or lactation, and children less than 16 years of age. Okay, these are the absolute indications. A few are the severe intolerance to antithyroid medication, large compressive or obstructive goiters. These are the absolute indications, okay, where radioactive iodine is not indicated. What are the relative indications? Severe Graves ophthalmopathy, okay, poorly controlled Graves disease requiring definitive treatment. Patients desiring pregnancy within 6 to 12 months of treatment. Patients unable to continue close follow up. And patients incompletely treated by initial attempts at radioactive iodine ablation. So this, in this patient, that is the absolute and relative indication, you subject the patient to surgery and not the radioactive iodine treatment. Okay, and in case of pregnancy, propylthiouracil, okay, is the antithyroid drug of choice. Methimazole in the first trimester. So what are the side effects? It can cause scalp defect known as aplasia cutis, choanal and esophageal atresia, facial dysmorphism in newborns, may spontaneously resolve in the third trimester. If surgery is indicated, then you have to do it in the second trimester. Okay, and here ends the topic.